very warm welcome to everyone and happy PR week. I'm just going to let everyone make their way through into this main room. Okay, right, I think that's just about everyone there. So I'll just start introducing. There may be some more people coming in as we go. So a very, very warm welcome to our webinar this evening. So it's our third webinar on pulmonary rehabilitation in our series from the ACPRC. Just some more people filtering in, apologies. Today I'm co-hosting with my colleague Rachel Colclough, who's the Vice Chair for ACPRC, and she's also the co-chair of the Task Force for Lung Health Pulmonary Rehab arm. So delighted to be co-hosting with Rachel this evening. This evening we've got a topic of kind of celebration alongside Pulmonary Rehab Week. We want to just use this opportunity to celebrate all that is wonderful about pulmonary rehab, which I'm sure I don't need to say any more about. And we're going to do that with some quality improvement projects. We've got three great speakers lined up to speak to us about a few different projects, which hopefully we can have some lovely discussions around, as I say, celebratory and kind of supportive. We're completely recognising the challenges and the turbulence to services that's still ongoing at the moment, and completely empathise with everyone's challenges that continue to go on at the moment. So we just want to really say thank you and empathise with you. We know everyone's really just tired. I'm hearing that a lot from everyone I'm speaking to. But we want to use this opportunity to showcase some of the great work that's still going on across the country. So in terms of our speakers, so we've got Flick, who's from the Mid Yorkshire Hospitals NHS Trust. She's going to speak to us first. And we've got Alice from the Homerton University Hospitals NHS Foundation Trust. And then we've got Emma from University Hospitals of Leicester. In terms of discussion and chat, we'd love you to put any questions in the chat box as we go along, so that my glamorous assistant Rachel is going to go through them for us, and will help us with directing the discussion after we've had each of the presentations. So we'll have about 5 or 6 minutes of presentation, followed by about 10 minutes of discussion for each. So please do put your questions in as we go along. Anything I've forgotten at all, Rachel?
No, that's great. I'm looking forward to it. Welcome everybody. Thank you, Lucy.
Brilliant, lovely. If we're all happy, then I'm going to invite Flick to speak to us first. So Flick is a specialist respiratory physiotherapist in Mid Yorkshire, as I say, and she's going to be speaking to us about a Band 4 technical instructor role in helping to reduce DNA rates. So Flick, if I can ask you to have a go at sharing your slides. Flick.
Okay, can everyone hear?
Yeah, just about. Can you try again?
Can you hear me okay?
Oh yeah, that's better.
Nice, okay. So thank you for the lovely introduction, and as you say, I'm going to talk to you today about the role of a Band 4 technical instructor within pulmonary rehab. So just to introduce the team really quickly. So I lead the pulmonary rehab team, and I wanted to point out very quickly, it looks like we've got a huge team, but these physios, the 2 Band 6s, 2 Band 5s, and the technical instructor work across both cardiac and pulmonary rehabilitation. The caseloads that we cover aren't just pulmonary rehab. We have a respiratory caseload, which is a mixture of chronic lung disease and neuromuscular disease patients. We have a breathing pattern disorder caseload. We have a pulmonary rehab caseload. And now we have a COVID-19 rehabilitation caseload. And we work across home visits, outpatients, virtual clinics, telephone remote management, and pulmonary rehab groups. So our Band 4 technical instructor role started in April 2018, and it's actually a rotational post around our community team. So they also go through neuro and generic service, dietetics, and then the cardiac and respiratory team. Initially, it was a 6-month rotation. We quickly realised it needed to be a 1-year rotation because they have so much to learn. We're learning as it's gone along. We set up a set of competencies back in April 2018, and they're reviewed in great detail every year. So the role of the Band 4 that is, I would consider a quality improvement, is all around the triage of our referrals. We discovered back in 2019, I wasn't the lead of the team at the time, that clinician-led triage reduced our initial DNA rates at pulmonary rehab assessment. We noticed that a lot were discharged at the point we were contacting them rather than admin just sending letters. We then noticed that the DNA rate reduced from what was near the average of 40% to a 14% DNA. We then realised that when with Band 6 and Band 7 diaries taking the hit with leading this triage, it wasn't the most effective use of our time. We then had the quality outcomes framework that was introduced in April 2019, where GPs were sending us an outrageous amount of referrals through for anyone with an MRC Disney score of 3. We then had the NACAP audit, the introduction of digital technology, and we soon realised that we needed something else to help us. So the pulmonary rehab triage is now led by the Band 4, and the Band 4 gives them a ring. They let them know that they've had a referral through to pulmonary rehab. They discuss who that referral was made by. I wouldn't be exaggerating when I say we get referrals that say, you know, ingrowing toenail and in the plan refer to pulmonary rehab, just so the GP gets those plot points. They give them a really detailed description of pulmonary rehab that has been laid out by me. So the details of the commitment involved, the fact that it's a physical education, physical activity and education programme. The TI4 then goes into some detail about how they're managing at home, and they are unravelling all sorts and saving us a huge amount of time by doing this at this stage, because patients haven't had contact with anyone for so long. They discuss transfers, walking, paddles, daddles. They look at equipment needs. Is there an indication for our Band 4 to go out and do an environmental assessment? We look at the main limitations that they're experiencing, and then some bits that, again, the therapist, the qualified member of staff would normally go through, so smoking status, pressure care, and mental capacity. We have got 2.5 days at the moment, in addition to the team that I showed you earlier of a Band 4 triaging for us. And we're using a system called net calls, so we're seeing how long these conversations are taking. They then go into some detail about, do the patients have data? Do they have the data-enabled device to be able to do virtual work? If they don't, we offer them the tablet loan scheme and put them in touch with the scheme in Wakefield that are offering those tablet loans. They're able to verify email addresses on System 1, discuss the options for rehab. At the moment, we're offering virtual, face-to-face and supervised with telephone support, individualised advice. They book the appointment, which often takes time. And then they task our admin team to get the outcome measures, the questionnaires we use sent out. So the CAT, the CRQ. They then offer My COPD, the app that we've got free licenses for. They activate it and offer telephone support with that. They give the information about NACAP. So that includes the patient information leaflet and discuss consent before initial assessment. And they're also involved right at the end with patient satisfaction questionnaires. Other roles around this involve helping us run the pulmonary rehab groups for the patients that come and want to have an exercise programme prescribed with weekly telephone support. They do that telephone support and offer some of the education, including pacing and energy conservation. They look at our discharges and are doing some of our discharge assessments. They're troubleshooting My COPD. As I said, they're doing environmental assessments. And on top of that, one-to-one cardiorespiratory exercise programme, particularly actually with critical care rehab and some of our really complex discharge post-COVID patients. So I'm sharing this, it's on the CSP website, but I think it's really important that we're all aware of some of the myths around support workers and how much they actually can do for us. So the first myth was around support workers being unqualified. So it's a massive misconception. They qualify, they're perfectly qualified, they're just not registered. Support workers have all sorts of qualifications behind them to allow them to work safely and effectively in their role. The second one was that there are laws and rules that can dictate what they can and can't be delegated to. Again, it's not true. It's a complex process and it's based on good decision making, but the limits of delegation are not as restrictive as you might think. There is a rule that clinical support workers cannot progress beyond that of a band 4, which again isn't true. The CSP described really careful considerations that should be made in practice to really encourage people that aren't registered to progress. And often qualified members of staff don't feel confident or comfortable with delegating to a support worker. So again, I just wanted to refer to the CSP website. So I'm not going to read through all of this, but my summary is that support workers are only able to do work that they accept, tasks and responsibilities that are appropriate to their role. They only accept tasks and responsibilities that are within local policies and protocols. They only accept tasks and responsibilities that they're competent to take. We need to make sure they've got registered healthcare professionals for support and that arrangements are in place to ensure that they maintain their competence. The support worker is accountable for agreeing to undertake a task or a responsibility. Once they've done that, so once they've accepted accepted that task and taken responsibility, they're then accountable for the acts and omissions that are related to that task or responsibility. So what does the future hold for us? Well, I'd love to take this back to the group really to find out if anyone else had band 4 instructors, because technical instructors or physiotherapy assistants. The more I work, the more I realise that their health and social care of 60 credits and to level 4 that we ask for is good, but I'm going to assume that the technical instructors would learn more from some sort of exercise instructor course. I know that the cardiac rehab back bar have a specialist exercise instructor qualification. Locally, we've got in touch with gyms and I'm trying to push for our managers to get our technical instructors through something more formal around planning gym-based exercise, instructing gym-based exercise, a bit more about anatomy and physiology that they wouldn't otherwise get in the health and social care world. So there's my references. Do you have any questions?
Lovely. Thanks so much, Flick, for a really interesting presentation. And it's great we talked about celebration at the start, and I think it's a great celebration of the support worker role, as well as the quality improvement side of it in terms of that drastic reduction in DNA rates. We need to celebrate that support worker role. Am I right, Rachel, in thinking we haven't got any questions come in yet in the chat?
That's right so far, so please do send us questions. It was a great talk, wasn't it? I agree with you. So I'll start fielding questions because I think they'll come in. But I wanted to just note actually, Flick, I think what you're saying is very much what the CSP are echoing. So Rachel Newton and I co-chair the Task Force for Lung Health, and we're very interested in roles, not just physiotherapy roles within the staffing of pulmonary rehab, so looking outside of perhaps that registered physiotherapist. And I think exercise is really interesting. I'm really interested with what you're doing, looking at local gyms and looking at training needs. I think that's fascinating. So I'll be quiet and I'll look at the chat. Lucy, over to you.
I don't know if everyone else is finding the same thing.
So there's a comment about in Hackney, there's a band 4 trained in cardiac rehab and working across cardiorespiratory services, and they wouldn't be without them, which I totally agree. It's a great project. There's lots of real positive comments, Flick. It's lovely. There's a new band 4 and it's been so helpful. So I wonder if it's an opportunity to share and link up our band 4s within PR regional networks. So that might be something that they might find supportive of each other.
That would be amazing.
It would, wouldn't it? I think that might be something that we could take forward, perhaps, Do you have Band 4s take up foundation degrees, Flick?
On that last slide there, that's the requirements on our job description. So minimum foundation degree in health and social care of 60 credits at level 4, and then educational level GCSE level A to C, and English and maths are equivalent. The role, I think, is now more complicated than it's ever been. I don't know if other services are finding the same, but our Band 4s are very good at not triaging something that they're not happy with. So we're seeing post-COVID patients with no respiratory history at all that have snuck in there onto the waiting list. We're seeing a lot of patients that by the time we get down the waiting list are palliative, very much end of life, and they will then task us on System 1 and we make the phone calls instead of them. They're spending an enormous amount of time having conversations with people that are just relieved to have contact with a healthcare professional that cares about how they're functioning at home. We're spending a lot of time when patients have been discharged in a rush, finding people in random respite beds and trying to get care home workers to get a phone to the patients to be able to triage the referrals. So the amount of time that our Band 4 technical instructor has taken from my hands has just been huge.
Lovely, thanks, Flick. And we did have a question from Claire come in, congratulating you on a lovely project. And can you explain a bit more about your QI methodology that you used in the project? So was it like a PDSA model, or what sort of approach did you take?
Yeah, so we actually went to a quality improvement workshop up in Newcastle. That's where we got the idea, and with it just a simple PDSA cycle. Our DNA rates were huge, and because we were taking an hour, we had 1 hour to do our assessments, and we were trying to argue that we needed longer because we just could not get the NACAP, the MyCOPD, a good proper assessment done in that time. So we felt like if we had initial contact and we could we just make our face-to-face contact much more efficient. So as I said, we started with Band 6, Band 7s doing it. We had time blocked out in our diaries, and as soon as we could prove that those DNA rates dropped, we then looked at a Band 4. Unfortunately, with COVID and with this, the Band 4 triage only just really started, well, it's probably been going for a few months now, 6 months maybe, and we haven't compared the DNA rates to before, but it's so difficult to compare because we're offering the most flexible menu of options right now that it's hard for them to DNA, because you know, if they have a virtual, we ring them if they're not there and they log themselves on, and they pick up the phone or pick up the house phone if their mobile isn't answered. You know what I mean? They can't hide from us as easily now.
Yeah, that's one side to doing things virtually and remotely, isn't it? So we've got a follow-up comment from Belle, just checking. She wanted to say they wanted to know whether Band 4s that are interested in apprenticeship and physio training. Does that make sense? Sorry, I should have read the first question. This was following, do many of the Band 4s take up foundation degrees?
Yeah, our service are really pro apprenticeships. We've got one TI4 going through the apprenticeship at the moment. We yesterday recruited an OT and another physio to go through the programme in Huddersfield. We haven't actually, and this isn't because we're not allowing them to come through the service, but we haven't actually had one of those apprenticeship TI4s working for us yet. That's the one at the minute is working within the neuro team. It doesn't mean that she won't rotate to us though. But we're very much let's train our own.
Yes. I think, Rachel, do you think it's about time? Should we move on for now? And any more questions, pop in the chat, and we'll probably have a little bit of time at the end for any final questions. Is that okay, Rachel?
Yeah, that's fabulous. No, that's great, Lucy. Thank you. I'm hoping that Flick's going to write this up for us for ACPRC Journal.
Yes, please. Yes, please.
Well done, lovely. Flick.
Thank you very much, Flick. So let us move on to Alice. So Alice Kenwood is another specialist respiratory physiotherapist working at the Homerton, so in Hackney in East London. and she's going to be presenting to us about a QI project around education in the Turkish language, because I know you've got a large population from that group in Hackney. So I'll hand over to you if that's all right, Alice.
Thank you very much. Let me do my best to share my screen. And while I do so, that Band 4 mentioned in the chat in Hackney is in our team, and she is absolutely fantastic and far too good for us. And she's leaving us in September to do the physio degree, and I fully expect to quit about a week after she leaves, because I don't think I shall cope. Anyway, can you see this okay? That's all right.
Yeah, that's great.
Okay.
Yeah.
Thank you. So this project was actually done pre-pandemic in 2019, and it was led by Nikki Anderton, who's currently getting wet in a tent somewhere in Cornwall, so she can't be here. It was looking at providing an introduction to pulmonary rehab and COPD education session for Turkish-speaking patients in Hackney. It was an imperfect project done in the real world, and it perhaps didn't follow the traditional PDSA model, so I should just preface that. So what we noted was that through our normal pulmonary rehab pathway here, the opportunities for non-English speaking patients were significantly limited. We have 8 hours of advocacy in total for ACEs in a month, which meant it really limited how much we could offer our patients. So we could provide an initial assessment with an advocate and maybe the first pulmonary rehab session, but beyond that we were very limited. 5.6% of the Hackney population described themselves as Turkish, Turkish Cypriot or Kurdish, and therefore 4.5% of the Hackney population would describe Turkish as their main language, which is the second most prevalent language, therefore. And here's our high Turkish population centred really around the south of the borough. So we know that our Turkish-speaking population really engaged quite poorly with the PR education talk, meaning they were less informed and less able to make a choice and therefore engage with pulmonary rehab as a whole. So our completion rates and attendance was much lower for Turkish-speaking patients. And we know that even if they did attend and complete our pulmonary rehab programme, they weren't getting the benefit from the education sessions, which is obviously a massive part of pulmonary rehab. And they didn't so much benefit from that group setting either. They weren't able to access the sort of camaraderie in the same way with not sharing a language. So we saw the need to provide an improvement and to try and reduce this sort of health inequality, if you like. So our aim was to provide disease or education on disease management and pulmonary rehab in a way that our Turkish-speaking patients could access, and therefore hopefully to increase the engagement of our Turkish-speaking population with the ACEs team, sort of raising our profile and enabling them hopefully to access all the different parts of our service. So we started planning for this, and we had to decide what was realistic. We didn't have any additional funding or staffing or time for this project, so it had to fit around our usual caseload. And we had to think about how we could therefore make this session accessible for our Turkish-speaking patients. So to sort of have an idea of those, we shadowed our locomotor, our pain team, who already have an education session for Turkish-speaking patients, and that sort of gave us some good ideas on setup and how we could just pragmatically make it work. So we knew we only therefore had about 2 hours. Because you know, this was already pushing an attention span, and we felt it wasn't realistic to ask people as our first move, I guess, to attend multiple sessions. We wanted to see how the one session went first, so we decided on some topics we felt would be most beneficial, and we asked our team, the ACEs team, to send across patients who they knew to be Turkish speaking, who maybe they hadn't been able to engage, or those who had engaged as well, so we could offer it as widely as possible. And from that we identified 22 patients. This sort of pilot thing. This moves on its own, this talk. It tells me when to stop talking. And we also needed to know whether the session was successful, and to do that we settled on a couple of different questionnaires. So we used the LinkQ questionnaire to establish if our patients had sort of learned anything, and a feedback questionnaire to get the patient experience of the session. Of course, we needed to get those translated into Turkish, and to do this, the only option we had really was to beg a favour. So we asked a bilingual Turkish English speaking colleague from a completely different team if she would translate those questionnaires for us, which she duly did. And then we tried to get them verified, but we knew so few bilingual Turkish English speakers that we in the end got very few responses that were quite inconsistent, some saying it was well done, others saying it looked like it had been passed through Google Translate. So we immediately didn't have that much confidence in our questionnaires, but at the same time our options were very limited, so we plowed on regardless. Okay, so let's see. This was how the day was then set up. Our patients arrived and we had 12 attend out of the 22 that we invited. 4 let us know they weren't able to come, 6 were just completely non-contactable. We had a single Turkish advocate present on the day, but we had them available for the full 2-hour session, obviously. And the patients, when they first arrived, were asked to do this link questionnaire, testing their knowledge of their condition and what they were aware they'd been taught by healthcare professionals. And as I say, translated into Turkish, and the advocate helped us with that. We then had presentations on pulmonary rehab, on COPD as a whole. One of our respiratory nurses came and talked about inhalers and inhaler technique. One of our psychologists came and talked about the emotional aspect of living with COPD. Some representatives from Smoke-Free Hackney talked about smoking cessation. And we had a wonderful expert patient who's Turkish speaking and wildly enthusiastic about pulmonary rehab, who came to talk to them as well. We had a break in the middle of all those talks, but then at the end we asked them to fill in the link questionnaire again and their feedback questionnaire. So the link results were fairly appalling because we didn't get any fully completed questionnaires. So we can only interpret the data a little bit and without vast amounts of confidence. So 2 patients who at the start said they didn't know the name of their condition said they did at the end. 3 who said they didn't understand how COPD affected their lungs at the start said they did at the end. 1 said they didn't know why they had inhalers at the start but did by the end. A couple felt more able to judge when to call an ambulance. And at the end, 8 out of our 12 patients felt they'd been told about exercise by a HCP, which is obviously good, it's the majority, but given we'd spent 2 hours talking to them about exercise, it wasn't ideal, but it's not bad, we'll take it. So as I say, that was really difficult to interpret from. It was slightly disappointing, but at least the results were generally positive. So our feedback questionnaire, we were slightly limited in having to ask quite a lot of closed questions so that we could interpret the answers without guaranteed Turkish advocacy to help us with that. 9 out of the 12 patients provided feedback responses, and over half said they'd recommend the session. All but 1 of them said they found the session useful. 5 said that they felt there was sufficient information. 2 said there was too much, and 1 said there wasn't enough. And the highest rated topics were education on COPD and inhalers. 1 patient in the free text stated that if they'd known it would take this long, they would have brought a picnic. The advocate, however, provided us with loads of feedback and insight that for some reason I hadn't really anticipated in advance. It possibly should have been obvious. He said that the talks, he was able to translate the talks well and that worked. He said he would have liked more information for the session, which I think was a totally fair point. But this underlined here was the most striking thing for us. He said that most patients attending the session were unable to read and write in Turkish. So it didn't matter really that we translated these questionnaires because their literacy levels were so low that they weren't able to use the resources, essentially the questionnaires we provided. And therefore we needed, he fed back, far more advocacy cover so that he could actually help them complete them, because he was having to do so much of the reading and writing for them that he couldn't do, 1 man couldn't do 12. And that was part of the reason our responses, I think, were so poor. So having done this day, having completed it, we reflected on it. We felt the talks went well. Working with advocacy, we felt we could have improved, so we could do more with the advocacy. The easiest way to do the talks is a very didactic teaching style, so that we say advocate translates, and when we tried to interact more, it became more chaotic and more difficult. But obviously in pulmonary rehab, we know we're moving away from a really didactic style of teaching. So I would like to be able to work with advocacy to be able to offer a more effective style than just standing at the front talking, because it's easier to translate. And we need to reflect on the discovery we made about their literacy, and consider then what else can we provide. Do we need to video with a translator talking over the top? You know, how can we offer something that people can in fact access? So we noted our limitations, limitations being the validity of the questionnaires, having translated them. Was the link still valid even? And how well were they translated? We weren't sure, because so few questionnaires were completed. To interpret those was really difficult. And of course, the literacy meant that maybe the questionnaires, or at least the questionnaires with the limited support we have, weren't even the best way to go. So the limitation of having so few Turkish speaking staff was a significant one. The time of the year, just that we ran this in the summer, and a lot of our Turkish patients tend to go back to Turkey and spend the summer there. So we need to offer more choice to allow people to access this in terms of time of the year. And then money. This would be great if we had a lot of money. Okay. So we had good attendance. The questionnaire suggested we were improving people, and some people at the end of this talk, it weren't many, but a handful signed up for pulmonary rehab. So we count that to be a success. However, I've been through some of these recommendations as I've talked, but two then that I would pull out would be that we know that Haringey and Enfield also have high Turkish speaking populations. So it'd be really good to link in with those boroughs and find out if there are any resources already existing that we could share. And that, as I've said, we need proper translation, we need more advocacy time. And if that means that we're going to need to ask maybe for more funding to support this, we're going to need a lot more data on referral numbers, completion numbers, you know, numbers of patients unable to access our service to make the case for that. We linked in with Derman, who's a Turkish speaking charity, or a Turkish charity in Hackney, but unfortunately they also need funds to support us. And then COVID-19 came, and things haven't got better. A lot of our Turkish patients aren't able to access digital platforms, it would see, or certainly aren't competent to do that in without advocacy support. So we've now got a long way to go to rethink our presentation from the start and apply it to COVID-19 limitations. And there they are, aren't they lovely? With Nikki in the middle, looking very proud of herself, and Katie, our band 4, in the background, doing what she does best, which is getting on with making things work with minimal fuss. So there you go.
Okay, thanks so much, Alice. I think it was a great example of trying to meet the needs of your local population, trying to make it accessible, but also showing us the real world and what limitations you face in terms of trying to do this kind of quality improvement work. But really, really interesting. I've got some questions, but I think there's already one question in the chat from Claire. So saying, congratulations again, thank you for your honesty. It's a great example of why we need to evaluate what we implement, not just do something because we think it's a good idea. Did you manage to estimate the cost of implementing this kind of service or session?
I mean, the easy answer to that is no, essentially, seeing as I've started on a very honest basis. I shall continue that way, however terrible it makes us look. So because we were doing it as very much without anything additional, we didn't calculate that. We used the same amount of we used the advocacy within the 8 hours of our service, and so I haven't looked at that, but you're right, it's probably something we should do. And in terms of evaluating, we just need to look at the data, for example, from those patients who then signed up to pulmonary rehab as well, and whether they ended up completing, did they make it all the way through? So there's lots of different things that we do need to evaluate. But yeah, cost is one that I'm always less confident with.
Yeah, and but it is a good, it's a really important consideration, isn't it? Because theoretically, if we can get more people from that population coming, then hopefully we can prevent primary and secondary care needs. Oh, and Laura's just added, we did put a bid together prior to the pandemic, which included running these sessions more frequently. The costs were included in staffing costs, so no broken down cost. And Claire just adding, not a criticism. I don't think many of us think of the cost of reorganising services, and we don't, do we? We don't.
No.
But
I'm
must be.
I'm just not a very mercenary person, you know. I need to learn.
No, absolutely. It's challenging at the best of times. So I don't think there's anywhere in the chat for now, but I as I say, I've got loads. I love these sorts of projects. I wondered, obviously literacy came up as a massive consideration, general literacy, which I experienced as well when in Tower Hamlets we were using a Bengali version of the CAT, and actually we discovered the same as you, that literacy full stop was the issue. So I'm just wondering, either from you, Alice, or anyone else in the group really, as to has anyone adapted materials to try and help with this challenge?
Can I speak?
Of course, go for it, Claire.
It's much easier than typing. I think actually this is something the researchers need to address, to be honest. And I've been doing a bit of reading around it because I'm looking at proms for pulmonary rehab. And I read a really interesting paper that looked at how many studies had made sure that their questionnaires were legible by people who either had learning difficulties or literacy difficulties, and a really small proportion were acceptable for people who had, you know, conditions like dyslexia, never mind looking at translations. So I think in a clinical setting, it's really difficult to do if the tools you're given aren't appropriate. But I think going forward, really simple measures like visual analog scales or numerical rating scales would be worthwhile. And then obviously consulting organizations like the Plain Speaking English, I think is their correct name.
Yeah, absolutely agree with you, Claire. I think we just really need to bear in mind inclusivity, don't we, moving forward? So many of our materials, including, I know that Rachel and I, we've reflected on some of the ACPRC materials, haven't we, and how they need to be more plain English and using images, as well as the translation side of things. Any other questions come through? Oh, go on, sorry.
I'll just add, we're actually filming on the 15th of July. I've got a registrar and a speech and language therapist who speak Urdu to do some videos for us of inhaler technique. And they're also going to cover a script that we've done on breathlessness management and chest clearance. And one of our consultants is hoping to share that with the British Thoracic Society. We've got medical physics coming. So yeah, watch this space. I think we're all thinking the same thing, aren't we?
Brilliant. Yeah, I think we are. And it might be something again to think about networking around. I know, Alice, you mentioned about having also having a large Turkish population. We do need to, this is one of the benefits of networking, isn't it? Right. Did you want to add anything, Rachel? I was going to move on in a moment for time. Yeah, but
I was just really interested, Alice, to see how the pain service locally to you were finding things. Obviously, you were trying to mirror their inputs. Do they give you any feedback on their service?
The pain service are lucky in that they have some advocates embedded in their service, because so many of the people who access it are Turkish speaking, so they have that advantage over us. And I think what we need to do is well, or something else that we can do is to speak to them and find out how we might be able to copy them. Yeah, I think their service runs well with those advocates, and it's sort of an embedded thing now. But apart from that, they have similar problems then to the other services in terms of DNA rates and uptake. But at least they have that equality and option to provide the service.
Sure. Fascinating. I think what we need to try and do as a community is share our resources much more and be more welcoming of each other's resources. I think it's fantastic, Flick, if you're doing some videos that potentially might reach a national body. The ACPRC, I'm sure, would be happy to hold resources on our website if that is appropriate. So I think that's great. So hopefully we can link up a little bit more and share the work that's going on. So well done. Thank you, Alice.
Brilliant. Thank you very much. So without further ado, let's move on to our final speaker, Emma. So Emma is a senior pulmonary rehab physiotherapist at University Hospitals Leicester, and going to be speaking to us this evening about reducing wait times to initial assessment. So I'll hand over to you, Emma, if that's okay.
Thanks, Lucy. Okay, so just to start and put you all in the picture, really, this was a QI project that really was started pre-COVID, so sort of around 2017, 2018. But actually, as we all know, with QI projects, it's never a finished product, is it? And they're always ongoing. And I think more recently, for us, going through the Pulmonary Rehab Accreditation service program, we've obviously had to look at QI in lots of detail, and it was really good to actually be able to reflect on what we've done, and then so it was a nice opportunity tonight to obviously share this with you all. So really on the background of it, it was based on the 2015-2017 audit figures, which obviously were just sort of snapshot 3-month audits, which initially showed that our service was actually doing really quite well with offering patients a start date to class within this 90 days of receipt of referral. But as you can see, it started to drop off between 2017 and 2019, and really this tied in at the same time when the accreditation service also brought the QI in for of 85% of patients should be enrolled within 90 days. So we really started to think like we need to really sort of look at this and try and do something about it. And at the time there was also a few influences, as Flick's already said earlier on. There was the quaff point from primary care, where obviously GPs were referring left, right and centre to, you know, get that money in. So our referral rates went up about 31%. But also for us, we were trying to look at other ways of working. So we'd integrated with cardiac rehab and done breathlessness rehab, which reduced our capacity in classes, but also we were trying to integrate with the community teams as well to do this integrated primary secondary care, which again cut down on our capacity for classes. So it was it started to have a knock-on effect on our figures, really. So a few of us went to the Royal College of Physicians QI days, which were really good, and we also had QI had become a really big sort of project within the trust, and so for one of our time out days we had the QI lead for the trust come to talk to all the teams. So that was both cardiac and pulmonary rehab teams, about incorporating QI into clinical service and sort of the importance of looking at doing it. And after we'd had our time out day, we managed to put aside some time to be able to sit and think about what QI projects we wanted to do. And because of this, time to enrolment from referral was actually increasing, we felt this was something, or one area that we address and look at waiting times to assessment or initial assessment. And hopefully this would mean that then patients would have a more timely assessment from referral, and hopefully also then be able to start class in a more timely manner as well. So we came up with this lovely driver diagram, which we were all very excited to use after we'd been on the QI days. So as you can see, the sort of the two primary drivers that we thought we could try and influence was to try and reduce the DNAs, and also to try and increase referrals that were coming to us, to try and make them more appropriate and more patient engaged as well, because there was sort of two sides to that one, in that inappropriate referrals from GPs, but also a lot of patients were coming to the assessments and didn't know what they were coming for. So we looked at those two main areas to try and have an impact on this waiting time to assessment. So to address trying to reduce the DNAs, we had in the past tried things like calling patients, you know, a week or 2 weeks beforehand to remind them they'd got appointments, but this was really time costly, and you couldn't always get hold of the patients. We thought about the opt-in letter for patients, but that didn't always feel the right thing to do to you know, when patients had been referred to you. And the other sort of idea that the team had come up with was to try and do maybe like a pre-session where you would invite patients to come to a group session where you would discuss what pulmonary rehab was, and then after that point you would book them an appointment for an assessment, because they would be well informed about what they were coming to. So with all of those in mind, we then also looked at amending the appointment letters that we were sending out to patients, because we realised this was probably quite a quick win with things, because when we read the letters, we could make a point of what the cancer, you know, what DNA would mean, that patients wouldn't have that opportunity. If they DNA'd, they would be discharged. They wouldn't get another appointment through. We also looked at the number of cancellations and rebooks, and we tended to find this a lot with the post-exacerbation patients, and which threw up a number of other questions around, was it the right time for offering patients to come to rehab? But we were finding within a month, we probably had the equivalent of a week's worth of assessments from cancellations and rebooks. So we decided to look into what our policy would be around those as well. So, you know, giving patients only sort of 2 chances to cancel and rebook, and at that point then they would be discharged and need to be re-referred to us. And there was a big in the trust as well around the two-way text reminder system as well, around appointments, which was a new incentive back when we were doing this QI project. So one of the interventions for us was to obviously get on board with that and be able to work that system. And that was a good way to know, obviously, if patients had text in or text back to the appointment reminder to say that they didn't want that appointment. And obviously we could then fill that appointment that had become free. So that was one of the areas that we looked at to try and improve the DNA rates. And then with increasing or trying to improve the referrals that we were getting, so we looked at the obvious things like looking at the referral form, you know, checking that it got all the information on there that we really needed to know from the healthcare professionals. We also had a community from primary care, an online referral form. So we went back and looked at that and tried to make that refined so that there were certain mandatory requirements from the GPs or the practice nurses that we needed on the referral forms to be able to accept it. So it was things like the correct MRC, a correct diagnosis, because some people were coming through with just breathlessness. You know, there wasn't much there to really be able to warrant knowing if it was the appropriate referral or not. And a lot of patients we were finding when they were coming through, we'd assess them. You'd go to do the shuttle walks, and actually it was their blood pressure that was, you know, a big problem, which then obviously put back them starting classes and being able to do their shuttles. So we made that a mandatory requirement as well about their BP status on the referral form for us, that they'd had a recent BP done. We also decided that with the appointment letters, there was an information sheet that went out, but it wasn't particularly informative really around what pulmonary rehabs and the different options that there were and where you could do it, because we were offering not only face-to-face classes, but the space manual and website as well. So we updated the patient information sheet that went out with the appointment letter. We also got involved with roadshows and patient engagement events, so with different CCG practices, trying to raise the profile of pulmonary rehab, of how to refer to us and also who to refer. And we also made really good links with the communications teams for the community services, the primary care. So in the GP newsletters, we were able to highlight and showcase around Pulmonary Rehab Week, those sorts of things. And we also attended some primary care upskilling events where, again, we joined forces with the community team and were able to present sort of the inclusion-exclusion criteria to pulmonary rehab, what it actually was, you know, where it was delivered, not only within the Leicester City, but obviously the community as well. Sorry, I've not skipped on my slide. That's just highlighting them a little bit more so people could see them and the solutions. Alongside this, we also increased the number of classes that we offered. So when we initially did the breathlessness classes, they were just one cohort, so we managed to increase those with having joined forces with the cardiac team and the community team. And once everyone had experienced running the cohorts and felt confident in doing them, we were then able to increase those numbers of cohorts. And also we trialled doing different ways of the education so that we could do back-to-back exercise classes but deliver education in a different way. Again, trying to increase capacity so people weren't waiting so long from their initial assessment and getting into class. And I think we decided as a team that actually it was slightly better to wait a little bit longer for an assessment but be able to go to class quicker rather than being assessed quicker and then having a long wait to class. We felt if we could get them assessed and then get them into class, you were more likely to get patients engaged and get them enrolled onto the classes in a timely manner, and then hopefully go through and complete as well. And as with anything, so the plan sort of going forwards, we've now sort of looking obviously with reopening of face-to-face, the plan is to try something different, so to try a two-stage approach to the assessment. So we were hoping to do the first part of the assessment by telephone call. So we've done a lot of work around changing the clinics, you know, the letters that go out to patients so that they know that they're going to be called within sort of a clinic time and have an initial assessment done. And from that, we can obviously then be able to see if patients were going to either DNA, obviously if they don't answer their phone, but more if they decline and they don't come to rehab. I think the team felt very much that whenever we had DNAs within the appointments, it was an hour and a half of time that was then wasted. So to try and make better use of that time, if we could do the first part by telephone call, obviously if they didn't pick up or they declined, we could book a number of patients into that telephone clinic, so your time is better used. And then if patients were happy to go ahead and do rehab, our hope is that we are then going to book them into pre-shuttle clinics, and they will come and do the pre-shuttles with us, so we get that face-to-face contact with them before they come to classes. And again, if they have any problems like blood pressure problems or mobility issues, that means they're not suitable for class, we again will be able to see that before giving them a class start date. So hopefully by the time we've done the initial telephone assessment, the shuttle, and then give them a start date, they're all ready and good to go, and will be into class in a nice timely manner, fingers crossed. There's also, especially with COVID, obviously, the need to look at other ways of working. So not only looking at around increasing capacity, because obviously class sizes are reduced. So it's looking at making the most of the time that we have in the gyms with patients. So looking at how else we could deliver education, but obviously increasing the profile of things like virtual classes, space and the website to try and reduce the demand for the face-to-face classes. And obviously there will be a need to review all of this once the face-to-face resumes, hopefully, and things get back to normal, a little bit more normal, so that we can really have a little look and see if we've had an impact on reducing waiting times, and hopefully, you know, getting patients into class in a timely manner. So small things that actually you realise that you're doing, you feel like you've not done anything particularly. They're not big projects, but then when you put them all together and you realise you've done lots of little things, that actually they do have a big impact on what you've done and how it affects the service.
Absolutely. Thank you very, very much, Emma, for a great presentation. It was really interesting you picked up on so many kind of different elements that impact on attendance there. We could talk about so much when we don't have time. Have any questions come through, Rachel? Otherwise I've got many.
Not specifically, but I think it's really interesting that we're using virtual communications much more readily than we perhaps were pre-COVID. And I guess what you touched on there, Emma, is similar to what Flick was introducing us to the idea at the beginning of perhaps a band 4 role, but certainly an introduction on the phone first. Thank you, Emma.
Yes, and that was something that came up quite commonly in the survey we did leading up to the documents around the remote delivery of pulmonary rehab from the ACPRC. We did a survey, and that came up a lot, that people felt that there really was a role for using telephone subjective as a bit of a screening process, which may well help in terms of waiting times. So many questions. What shall I ask then? But do send any in that you have. Oh, I know. I was going to mention you mentioned that you thought about the introductory session, and I know that I believe Hackney ACES team have been doing their introductory session, or prior to COVID. I wondered if either Alice or Laura just wanted to tell us a little bit about your introductory session, because it's so linked. I'd be interested to hear.
Yes, so we started our introductory session because our clinic attendance rates were so poor, and we were just losing so many hours, sort of clinician hours, to sitting waiting. So our pathway became that anyone who was referred external from the ACES team was sent a letter inviting them to this group session, where we would do a talk that included the introduction to pulmonary rehab and the benefits. Again, our psychologist was there. We would have an expert patient, which I have to say our patients really loved. It was probably the part that they enjoyed the most. And then, oh, my clock's going to strike. I'm really sorry. And then they were able... And of course it's 9, so it's going to go on for ages. and then they were able to sign up at the end. So if they didn't want to sign up, you know, they didn't have to, and we did ask them to let us know if they weren't going to, why. So if it was something we could change, we could. And it was really successful in reducing the number of sort of lost hours. I think it might even have been something huge, like 119 across the year or something like that. So it was really beneficial in that way. But obviously it didn't address the number of people that we lose because they never show up, because we didn't get to have a go at them. But it was really beneficial pre-COVID.
I think Flick touched on it as well earlier, that actually patients can't escape you. So if you're doing like a telephone clinic, you know, I know during the pandemic, we just converted all of our assessments to just doing them over the phone, and, you know, doing questionnaires and everything over the phone, just to see us through sort of thing. And you know, the uptake obviously, and patients had telephone calls to do their exercise program at home. You know, you managed to capture them pretty much most of the time because they weren't out doing anything else either. So it made all the completion rates look really good as well. So
just say I would never forget the patient who said there was someone at the door and asked us to call him back, and then when we called him back had blocked our number. So they can escape you if they really, really want to.
They can if they want to. On that note, I don't want to end there because there's so much we could speak about, but I'm aware it's gone 9, so I think we had better sum up there. And thank you for the comments as have been going on, and I hope you'll agree that it's I've certainly really enjoyed hearing about your great work that you've been doing pre and both during COVID and throughout. And it's been a really lovely celebration of everything pulmonary rehab, and it's so clear that you just want the best outcomes for your patients. Anything you want to add in, Rachel, before I do my thank yous and sign off?
No, thank you everybody for your time, and we had some really lovely comments coming through, so well done to all speakers, and just wonderful to celebrate Pulmonary Rehab Week. It's been an unusual week compared to pre-COVID. I think we took for granted what it was to be able to see our patients in the flesh, so well done to everyone. Thank you, Lucy.
Yeah, thank you so much to our speakers for your time this evening, and for giving us those lovely presentations and rich discussion. Thank you very much, Rachel, for co-hosting with me this evening. Thank you everyone for joining, and a thank you to Claire Nolan and Teresa Harvey-Dunstan as well for their support in putting all of these webinars together, including this one. But I'll leave you to the rest of your evenings. We'll be in touch about another webinar in a couple of months' time. All right, take care, everyone.